Hi, my name is Whitney Eng, and I'm a pediatric hematologist-oncologist at Boston Children's Hospital and the Dana-Farber Cancer Institute. My research interests include outcome studies for vascular anomalies and the use of targeted therapies. Today I'm excited to give an update about clinical features, treatment approaches, and outcomes for KLA. As we know, KLA is a rare aggressive lymphatic anomaly. It was first described as a distinct entity from GLA in 2014 and is characterized by coagulopathy and recurrent effusions. Safe biopsy can often be difficult. Respiratory failure and hemorrhage lead to high morbidity and mortality in this disorder. To briefly summarize the paper published in 2014 by Dr. Towe and others, this was a retrospective review of 20 patients. The median age at onset for the disorder was 6.5 years, and the median interval between diagnosis and death was 2.75 years. Despite aggressive multimodal treatment, 5-year survival was 51% and overall survival was 34%. These results highlight that KLA is one of the most challenging disorders that we treat. This is an abridged list of some of the therapies that were used for KLA at the time. It's important to highlight that surgical interventions were a mainstay of therapy, with pericardiocentesis and pleurodesis being the most common. Sirolimus was just starting to be used for this disorder. Okay, that summarizes where we were, but where are we now? The goal of this next study was to provide an update on clinical features, treatment, and outcomes for KLA. It was a retrospective review of patients identified through the Lymphatic Anomalies Registry. It included 20 original KLA patients and further evaluation of those patients and additional follow-up data for the 12 patients who survived. It also included 30 new patients not previously reported. This table describes the demographics for the cohort of 50 patients. There was a female predominance and the majority of patients were white. There was histological confirmation of KLA in 62% of patients. As we know, biopsy in these patients can often be difficult due to thrombocytopenia, tenuous respiratory status, and hemorrhagic effusions. So the diagnosis can often be made clinically or radiographically. Surgical intervention was required in more than half of the patients at diagnosis. Thrombocytopenia is a common feature for patients with KLA, and the median platelet count at diagnosis was just over 100,000 cells per microliter. Not all patients demonstrated thrombocytopenia, however, and there was missing data for this variable for 10 patients. The median age at onset was 5.3 years, and the median time from symptom onset to KLA diagnosis was almost 1.5 years. I think that this variable is a really important feature of the registry, as this was self-reported from families and it's often not captured in the medical record. Time from diagnosis to death was 2.2 years, and the median follow-up is almost 7 years. This figure demonstrates the anatomic distribution of disease for KLA. It's important to highlight that mediastinal involvement and lung involvement occurred in a majority of cases, but notably not all. This is different than the original published report, which showed mediastinal involvement in all 20 cases. Abdominal involvement is a category listed in the registry, and it can be a bit confusing. This includes liver, pancreas, and the large and small intestines. Splenic involvement is denoted separately and occurred in almost 40% of patients. Effusions are an important feature of KLA and often aid practitioners in recognizing this disorder. 34% of patients had pleural effusions. Chest tubes were placed in 70% of those patients. Pericardial effusions were present in 24% of all patients, and 58% of those patients with a pericardial effusion had a pericardial drain placed. These pleural and pericardial drains were in place for a long time. There was a median of 14 days for the pleural effusions, chest tubes, and a median of 12 days for the pericardial drains. And as you can see, some patients had had drains for up to 76 days, and even one patient with a pericardial drain that was present for 240 days. This highlights the importance of surgical and interventional management in the treatment of KLA. It also speaks to the acuity of these patients. What can be said about medical therapy? Sirolimus was a mainstay of therapy, with 60% of patients being treated. The median duration of sirolimus use was 29.2 months. 80% of patients treated with sirolimus reported improvement as measured by either improvement in patient or parent-reported quality of life, or improvement in coagulopathy, or decreased size of lesions on radiographic imaging. This had to be sustained for greater than 6 months to say that this was a response. 8 patients had sustained response with sirolimus monotherapy. 18 patients had response with combination therapy, including steroids and/or vincristine. 4 patients did not respond to sirolimus, and at this time, 20 patients remain on sirolimus. This is a Kaplan-Meier curve depicting overall survival for the cohort. The red line depicts the 20 patients identified between the years 1995 to 2011. The 5-year survival was just over 50% in this group. The new cohort, represented in blue, depicts patients identified between 2012 to the present. The 5-year survival for this group is 88%. It's important to note that there is a clinical practice change in the two groups, with use of sirolimus becoming more common in recent years. So just to go through the numbers, in the red, 25% of patients were treated, and in the blue, 67% of patients were treated with sirolimus. This figure shows the characteristics of patients who lived versus the characteristics of those who died. Clinical findings represent the presence of these features at any time, not just at diagnosis. There were certain characteristics that were more common in the patients who died, including lung involvement, bone involvement, bleeding requiring transfusion, and the presence of effusions. And these differences were statistically significant between the two groups. On the right are the p-values for the Wilcoxon-Rank sum test or the Fisher's exact test, respectively. To summarize the key findings, this study supports the fact that KLA remains a disorder of younger children. It was important to learn that patients continue to have a gap between the time of initial symptoms and the time of diagnosis, which was greater than 1 year. This length of time was not statistically significantly different between the historic patients versus the patients identified more recently. In other words, it's still taking a long time for this disorder to be diagnosed. Increased awareness among practitioners is important, as KLA can mimic other more common disorders. High-risk features include those that we've already discussed and are listed here. Sirolimus seems to be helping, but there are still patients who progress on this therapy, and 4 patients who received sirolimus still died. In the future, it'll be important to look at the timing of initiation of treatment as a potential area of research, and also to evaluate the role of new therapies such as MEK inhibitors. Evaluating the use of those targeted therapies was an important focus of future work. This is a bit of a preview on this. Genetic testing at our center has revealed 6 patients with the NRAS mutation previously reported in KLA. 4 patients with a histopathological diagnosis of KLA had, quote, negative molecular results, demonstrating that this can often be difficult to determine. Many patients with a clinical diagnosis of KLA were unable to undergo tissue biopsy, and highlights the potential role of testing and cell-free DNA from lymphatic fluid. In terms of treatment, 4 patients at our center are being treated with trametinib, and they've had improvement in hemoglobin and platelet count. Longer follow-up is needed to report on the durability of this response. I did want to comment on an important finding within this cohort in regard to race. While numbers are small, it's notable that the majority of KLA patients were white, making up 68% of the cohort. White patients represented 29% of deaths. Non-white patients were a minority, representing 14% of the cohort. They represented 57% of deaths, however. These numbers are limited by missing race data for some patients, but I think they highlight a potential difference in outcomes and a possible health disparity. As we know, care of patients with KLA in particular requires recognition of this rare disorder and referral to a center with expertise. I leave this finding as food for thought about additional factors that may play a role in poor outcomes, especially as we think about the barriers that are associated with genetic testing, access to targeted therapies, and insurance approval of these therapies. The registry has been amazing in obtaining important information about this rare but devastating disorder. The registry is currently being revamped with revision of data fields, matching diagnosis to current ISFA classification, inclusion of genetic information. We can't study what isn't captured, and I think it's important that we include information on social determinants of health as we build these registries. It's important for us to continue to establish natural history and responsive therapy to guide future outcomes for CLAs, to expand to include a biorepository, and to collaborate through the Canvas Consortium. KLA is just one of the disorders represented in the Lymphatic Anomalies Registry, but an important one. Currently, we have almost 1,000 patients with lymphatic anomalies in the registry and are always interested in including more. If you're interested in joining the registry as a patient or would like to refer a patient, please email us. With that, I want to thank all of our collaborators, funders, partners, and especially the LGDA for the opportunity to present this work. I also want to thank our patients who are the driving force behind all that we do and inspire and motivate us to do better.